Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Community Liaison, and it's my pleasure and privilege to serve as the host of the CGNE Seminar Series. We're very fortunate to have Jenny Rank join us as support. So if you want to unmute or have a question to ask aloud later during the discussion session, Jenny will assist with that. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carroll Neese College of Nursing in collaboration with the Office of Outreach and Professional Development and the Center for Nursing Research, as well as Age Friendly Care Pennsylvania. Today's seminar, Deciphering the Interplay, Psychological and Physiological Stress Impacts on Cognitive Impairment, Opportunities for Early Risk Detection and Prevention, will be presented by Dr. Julia Souza-Talarico, Associate Professor at Iowa College of Nursing, who is affiliated with our friends at the Some Center at the University of Iowa. Before the presentation begins, we do have some disclosures and announcements. Penn State Ross and Carroll Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and accreditation. Participants with a valid RN license who attend the entire Nursing Continuum Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. We do record Zoom in and out times as part of the attendance evaluation, and all RNs are required to complete the post-event evaluation survey in order to receive contact hours as well. We do, however, encourage all participants to complete the evaluation, which will be available at the end of the seminar. Jenny will put the link in the chat, and we'll give you a few minutes to get started on that. As I mentioned earlier, we do encourage you to share your comments, add insights, or ask questions following the lecture. You can put those into the chat, or you can raise your hand and Jenny will unmute you to share your thoughts aloud. In terms of contact hour certificates, RNs will receive those within a month after the conclusion of the seminar. If you have any questions or comments, you can always reach out to us at cgne@psu.edu. Next, I'd like to introduce Amy Christatello, one of our current CGNE DNP student affiliates. As an advanced practice nurse, Amy has focused on mental health and access to care for older adults. Her current program of study involves doctoral nursing practice in clinical leadership. She's very engaged with our center and was recognized as one of our DNP student champions in 2023. Thanks for introducing our speaker, Amy.
Thank you, Janice. My pleasure to introduce Dr. Juliana Talarico. She's an associate professor at the University of Iowa's College of Nursing. She's a leading researcher in the field of psychosocial stress and cognitive decline within aging populations. Her work identifies early prevention opportunities for fostering resilience against cognitive health issues that derive from sustained stressors. Her significant findings unveiled that environmental and psychosocial stressors cumulatively cause biological damage, leading to increased risks of cognitive decline. Dr. Talarico's recent work revealed that distinct patterns of dysregulated physiological stress responses can predict a transition from mild cognitive impairment to Alzheimer's disease. This finding can support individual-based digital models for dementia risk screening and monitoring and primary care prevention. She strongly believes that midlife is a critical phase for detecting modifiable risk factors and altering cognitive trajectories towards optimal aging. Supported by national and international funders, her work in dementia and nursing research continues to advance with the collaboration of innovative colleagues and promising students. I'll turn it over to Dr. Talarico.
Thank you so much for having me today, and especially during this prestigious and rich time of research discussion. So I'm going to share my screen. Can you see the big picture?
Yes, looks great.
Okay, great. So as kindly Dr. Amy introduced me, I'm Juliana Talarico, and I've been working in the College of Nursing as an associate professor and a leadership member in the SOME Center. And in this talk, I will be exploring the Alzheimer's disease and other dementia from the perspective of a progressive cognitive decline, and you'll be relating it to chronic exposure to stress. So I will show some evidence linking psychological and physiological stress measures to cognitive decline and Alzheimer's disease risk. And ultimately, I will argue that detection of risk using integrated models and personalized resources procedures at early stages of mid-age life are promising avenues to explore timely intervention and also primary prevention. As you might know, Alzheimer's disease and other dementia prevalence, it's estimated to keep increasing around the world. Actually, the dementia prevalence will almost double every 20 years, reaching more than 130 million in 2050. And the higher SME rates are expected to be in developing countries and underrepresented groups, such as Black and Hispanic older adults. You also might know that Alzheimer's disease pathology, that is amyloid, tau deposition, and changes in the brain structure with hippocampus atrophy can start 2 decades before the onset of the disease, meaning that individuals between the ages of 45 and 64, which include myself, probably already suffer from silent but advancing AD pathology. So although we know that, detection at preclinical stages remains a challenge. And there are some reasons for that. One of them is, as you can see in the left side picture, the Alzheimer's disease biomarkers that are detectable at preclinical stages require invasive and high-cost procedures, which limit accessibility. And second, amyloid and tau deposition follows a pattern that it's not uniform. As you can see in the right side picture, some individuals with amyloid and tau have quite stable cognitive performance over the years, while those with deposition on a specific brain area, such as the medial temporal lobe, have a faster cognitive decline. Together, those findings suggest that there are underlying factors influencing not only Alzheimer's disease risk, but also the disease progression. And together, that these two limitations challenge risk detection at early stages, which is critical for primary and secondary prevention and to reduce Alzheimer's disease pathology and delay the onset of cognitive decline. And this is the main background that I've been using to frame my research program. So what we know so far is that modifiable risk factors are likely to explain the difference increases of dementia across populations. So modifiable risk factors contribute to almost 40% of global dementia, much more than genetic factors as we usually learn in the past. And also around 70% of older adults have at least one chronic condition. So what it's promising, it's that some estimates shows that reductions of 10% per decade in the prevalence of modifiable risk factors can reduce Alzheimer's disease and other dementias by around 10%. So this means prevent almost 11 million cases around the world. Curiously, several of those risk factors, such as hypertension, diabetes, sleep, obesity, social isolation, are also associated with prolonged exposure to stress, which suggests a potential role of stress in the course of the disease. And as a nurse and a researcher sensible to the huge negative impact of dementia to patients' life and their relatives, I've been putting efforts to demonstrate why and how prolonged stress can contribute to the development of Alzheimer's disease and other dementia. Before I start explaining the connection between stress and Alzheimer's disease, let me briefly explain what is stress, what is the type of stress that I'm talking about during my presentation, and their psychological and physiological triggers. So the main type of stress that play a critical role in our health outcomes is the psychological, psychosocial stress, because are the main stressors that we have in our daily routine. Psychological stress is a response triggered by four main determinants: novelty, which means a situation that it's new; unpredictability, meaning a situation that there is no way of knowing what would occur. You cannot prevent or anticipate. Threat to the ego, which means threat to your personality, to your skills, feeling that your competence is questioned, or you have the perception that you are social evaluated in a presentation like that, for example. And finally, a sense of control. So having the feeling that you have little or no control in a situation. When our brain detects a situation like that, like novel, unpredictable, with social evaluation, or a situation you don't have enough control, we stimulate some brain areas such as the hypothalamus that produce cortisol hormones, CRH and ACTH, and those hormones will reach our adrenal glands, and through different areas of adrenal glands, cortisol and adrenaline will be released in our bloodstream. And the main reason of that reaction is to produce an adaptive response. So our body needs more energy and optimize the use of energy. So that response that we call as allostasis, which means an increase in the physiological responses with more cortisol, adrenaline, epinephrine, glucose, pro-inflammatory cytokines, all those primary mediators, they will increase to provide this energy in enough level to allow us for two actions: get away of the situation or face the situation, confront with that situation. The well-known flight or fight response. The problem is a lot of our psychological stressors are prolonged over the course of our life, or are even repeated, depends on the specific time that we are living. So, and which means that repeated hits of this response, as you can see in the picture, can produce sustained cortisol and glucose release and pro-inflammatory mediators that can start changing our insulin resistance and also increasing our blood glucose levels. So, and over time, if that repetition is just sustained and there is no adaptation, so there is a lack of adaptation, as you can see in that picture with red and blue lines, what it's going to happen is our cells, it's going to face those damage, face those effects. And this will produce more oxidative stress, more inflammation. And in the course of time, this will change our cell functioning. And what it's going to happen is over new stressors, our response tends to be dysregulated. And that dysregulation could be a prolonged response. So you reach a peak, but instead of have a recovery and a decrease in the physiological stress mediators, our response tends to be sustained, increased. Or we have inadequate response, would mean not a peak and not a recover. We just don't produce a response that would be enough to promote that energy and face a new stressful situation. So those types of changes in our physiological response to stressful situations could be a sign, a preclinical sign of cell dysfunctioning. And this just seed the environment for disease over the course of your life. So it increases the risk for stress-related disorders such as cardiovascular disorders, immunological disorders, and cognitive disorders. And this is the main framework that I've been using to explain the connections between stress and cognitive decline. What it's also important to know is there are windows of vulnerability that goes between prenatal and aging stages of life, whereby sustained exposure to stress may permanently alter how our stress system reacts to forward stressors. So the effects of chronic stress at different stages in life depend on the brain areas that are developing, as you can see in the red line, in the blue lines, or declining, that are the red bars. So depends on that, and at the time of the exposure, this will explain the potential effects related with a prolonged exposure to stress mediators. So bringing it to the midlife and aging, the brain regions that undergo the most rapid decline as a result of aging, that you can see in the red bars, amygdala, prefrontal cortex, and hippocampus, they are highly vulnerable to the effects of stress hormones and other mediators, such as the pro-inflammatory and inflammatory cytokines. Stress during these periods can lead to the manifestation of incubated effects of early adversity on the brain, which could be during our adulthood, during our mid-age life. We don't see any symptoms, but we are just accumulating all those damage. And it's likely that without adaptation and increasing our resilience, we can face these negative effects when we are older. The main theoretical framework that I've been using to connect stress and cognitive decline are related with stressors and when they are present in the patient's in the participant's life, the stress response, which could be psychological responses, such as subjective stress evaluated through questionnaires, or behavior coping or emotional regulation, or physiological measures of stress, which we can use through the main mediator of stress response, cortisol, and that could be measured through stressful situations and non-stressful situations. And finally, using a measure that can explain the interaction of all those systems related with allostasis and allostatic load and how they connected could pre-sign these preclinical stages. And the primary outcomes that would be Alzheimer's disease biomarkers being related with those stress measures, and how those measures are also related with secondary outcomes, meaning cognitive decline and Alzheimer's disease risk. So in that context, several years ago, during my PhD, I explored stress measures, particularly cortisol, salivary cortisol measures in the context of a pathological aging. So analyzing that relationship in patients with mild cognitive impairment, MCI, and Alzheimer's disease, mild Alzheimer's disease. We observed in a sample of 120 individuals with Alzheimer's disease and MCI, that the higher the cortisol concentration in the morning, the worse their memory performance. And the inverse relationship in the control group, meaning people without cognitive impairment. So these finds suggest that there is a U-shaped inverted relationship between cortisol and memory from normal to pathological aging, which means that the relationship between cortisol and cognition will change over the course of the disease. And this just highlights to me that would be important to explore what happened before aging or before the patient started developing Alzheimer's disease or other types of dementia. So the main question that I've been pursuing is, does the prolonged exposure to stress seed the vulnerability for developing cognitive impairment later in life in the same way that the theoretical framework proposed? And aligned to the pathophysiological allostatic states that I showed to you, and that reflect abnormal stress responses profiles, I will show here some key findings from my research program that link these stressors, physiological and psychological stress measures, to cognitive decline and Alzheimer's disease risk and disease progression. I will concentrate to show some of our research program findings, especially because they can show that connection between exposure over time. So in this longitudinal study, using a cross-sectional findings, we showed a significant relationship between work stress that we measure using questionnaires and cognitive decline that we measure using neurological tests, cognitive tests, in a sample of almost 10,000 mid-age adults without cognitive impairment. And we found that high work-related stress was associated with lower performance on delayed recall, on verbal fluence, and also in executive functioning tests. And we also saw that social support in the workplace mediate that relationship. So together we show that we can see that at early stages, although they are normal, there is no cognitive decline. People that are under high stress in their work environment, they start performing poor in some cognitive tasks comparing to those who didn't report high levels of stress. With them, bringing that perspective to the highly stressful jobs, which means, for example, nurse in the hospital settings. So we demonstrate in a sample of more than 200 middle-aged nurses that higher work effort that we measure, again, using questionnaires, were correlated with high perceived stress that we use a scale to measure, PSS, overcommitment at work, and a trend to significant association with cortisol awakening response, which is a measure of cortisol in the morning when we expected to see an increase, an endogenous cortisol reactivity to our morning demands. Cortisol was associated with depression and anxiety symptoms, and interestingly, overcommitment was also associated with depression and anxiety symptoms, and that relationship was mediated by higher allostatic load index. So we can see, although not all those components were analyzed together in the models, we could see that we have a connection between stressors, work-related stress responses, behavioral responses, and also physiological responses, and cognitive and mental well-being outcomes. So in that case, we saw relationship with psychiatric symptoms and anxiety and depression, but we did not find any relationship with cognitive decline. Looking at moving forward at the aging stage, after looking at those relationships in mid-age stage, we starting seeing how that relationship is in older adults without cognitive impairment. And in this cross-sectional study composed of 106 years old and older adults, we evaluated cortisol reactivity to a psychosocial stress, which is a extensively used and validated laboratory stress test that we call Trier stress test, TSST. And that test induced the stress response by exposing the participant to two tasks. One that it's public speech, and the other task is a mental arithmetic task in front of a panel of experts. And the idea is to mimic the four determinants of stress: unpredictability, novelty, social evaluation, and low sense of control. And we also collect saliva samples before that test, immediately after, and over the course of recovery period after the exposure to this psychosocial stressor. And we collected saliva samples to analyze cortisol reactivity and recover to baseline levels. And what we observe is a greater cortisol increase, as you can see in the left side picture, induced by TSST, the psychosocial stress, in men compared to women. So men, they had to have higher cortisol reactivity comparing to women participants. Interestingly, this cortisol increase was also associated with lower declarative memory performance, which was more pronounced in men than in women. So again, showing that there is a connection between stress and cognition, and there is an effect of aging and also sex regulating that relationship. So we move a little bit further and still in the aging context, but now we explore that relationship in individuals with subjective cognitive decline, which is considered a preclinical sign of dementia by some authors. So subjective cognitive decline combined with other factors can explain, are related with higher risk to convert to dementia compared to other adults without complaining about their memory. So what we observed was that the higher they complain about their memory decline, the higher their allostatic load index. Again, that it's a combination of cortisol, metabolic, inflammatory, and cardiovascular blood measures. And then we convert that to an index. So the higher they complain about their memory, the higher the allostatic load index, the higher the perceived stress levels, and the lower the cortisol reactivity in a sample of 240 individuals 60 years and older. So what we are seeing, it's a pattern of changing that relationship. So in adults without a cognitive problem or without a complaint of their memory, we see that sex and age influence the relationship between cortisol and cognitive performance. And here what we are saying is when we look at individuals with cognitive decline, which could be a pre-stage of dementia, we saw an opposite relationship, lower cortisol reactivity instead of hyper cortisol reactivity. And this is also related with higher perceived stress and allostatic load index. Looking at another group of individuals that started in the study as healthy older adults and following them in a period of 5 years, we demonstrate that cortisol reactivity to endogenous and exogenous, meaning cortisol in the morning awakening response and cortisol to a psychosocial stressor, the TSST, increases the risk to develop cognitive impairment 5 years later. So in individuals without cognitive impairment, 5 years before the diagnosis, participants who develop cognitive impairment showed lower cortisol concentration before the TSST test, the lab stressful test. But the cortisol reactivity to TSST was higher in the individuals with cognitive impairment. And we also saw that the probability of the probability of cognitive impairment increased around 6% for each unit of cortisol induced by a stressful situation, which suggests that the higher the cortisol reactivity, the higher the probability to develop cognitive impairment. We control all those analyses for age, sex, and education level because we know that they are non-risk factors for cognitive decline. So in summary, we found here a relationship between cortisol reactivity to awakening demands and also cortisol reactivity to acute stressful situation being related with the risk for developing cognitive impairment later in life. More recently, in almost 400 individuals with mild cognitive impairment, 50 years and older, we saw that conversion to Alzheimer's disease was significantly associated with changes in allostatic load index over 12 months. So we measure allostatic load index from baseline to 12 months. We analyze measures of allostatic load at baseline and 12 months, and we look at changes over that period. And we saw that those changes were related to higher risk to convert to Alzheimer's disease, even controlling for non-risk factors such as ApoE4 allele gene, a genetic risk factor, and also to age, sex, and education level. So specifically, what we can see in that table is that 1 point increase for the mean in allostatic load index change was associated with 50% increase in the odds of conversion to Alzheimer's disease. So then we try to understand what happens in that period of 12 months. Some individuals could increase, some individuals could decrease. What are the profiles during that 12 months measuring allostatic load index and how those profiles could be related with risk to convert to Alzheimer's disease? And in the same group of participants, we observed that sustained patterns of increased allostatic load, meaning someone that started in the study with high allostatic load levels and after 12 months was with even higher allostatic load levels, they presented almost 4 times risk of conversion comparing to participants who had allostatic load decreased, which is very intriguing, very interesting. So what we are seeing in that picture is that individuals who had their allostatic load increasing over 12 months, they had more risk to develop Alzheimer's disease. But those MCI individuals who started high, but for some reason, their allostatic load index decreased over 12 months, they were stable in a period of 36 months. So they didn't convert to Alzheimer's disease. And this is interesting because it shows that maybe allostatic load index can capture not only risk, but also risk of disease progression. And maybe this is a question for the future, by lowering, getting low allostatic load levels using preventive interventions, we may keep cognitive stability. And this is one of the questions that we would like to test in a soon future. Looking at the influence of allostatic load on the Alzheimer's disease biomarkers in an attempt to explain the mechanism. So, okay, we saw a relationship between stress markers, stress measures, and cognitive decline, and also risk for Alzheimer's disease. But what is the mechanism that allostatic load is influencing the risk for cognitive decline? So what we saw measuring, analyzing data, amyloid concentration, and allostatic load profiles, we didn't find an effect of allostatic load on the amyloid level changes over time. So no effect of allostatic load on increase in amyloid levels in a period of 12 months. But we found that there is an interaction between allostatic load profile and gender. So specifically, we saw that females with increased allostatic load profiles showed faster changes in amyloid compared to decreased allostatic load profiles. So there is an influence, but this is gender related, which is also interesting because we know that women are the group of people that are under higher risk for Alzheimer's disease compared to men. And finally, we found an association between allostatic load profiles on hippocampus reduction over time. So increased allostatic load profiles showed faster hippocampus reduction compared to decreased profiles. And we also controlled for non-risk factors related with Alzheimer's disease. So bringing everything together, our findings connect environmental and psychosocial stressors at midlife and aging stages of life to physiological and behavioral stress measures, and also to Alzheimer's disease biomarkers, amyloid and hippocampus reduction, and also a link to disease, Alzheimer's disease risk and progression. While we considering also non-moderators such as age, sex, education, and also some protective factors such as social support. But we still have a lot of questions to address. So, for example, we still don't know how the risk factors interact and how they are associated with brain changes that we can see in the disease. We also don't know how do the risk factors vary among diverse populations, especially because our psychological stress will potentially be different in our daily basis when we explore and take into account cultural differences and also the way we respond to psychosocial stressors. We also don't know when in life does interventions have the greatest impact. It has to be around 45 years old. It has to be earlier. What is the window of opportunity that we can increment interventions to increase, to power our resilience in order to reduce this prolonged damage and cumulative damage related with prolonged exposure to stress mediators? And what are the most sensitive and specific and cost-effective procedures to answer to assess risk and change through early stages? So what we have collaborating with our challenging questions is the advance of artificial intelligence resources. So using, for example, machine learning models, we can get together all these different stressors and biological responses, and also moderators and mediators in a very complex model, and predict with accuracy the individual risk. And we can also identify what are the main factors that are predicting or explaining that risk. And this is really essential to develop personalized screening tools, which is so essential to motivate people to be engaged in preventive strategies. Instead of giving them a list of what you have to do to improve your life, we could use those models to detect what is the specific risk factor or factors that you have as an individual, and what are the potential interventions that we can do in order to reduce those damage and reduce your risk to develop dementia in the next 10, 15 years. And more than this, we can also use that screening toward these measures to monitor how those interventions has been effective, and motivate the patient to keep working on that, because their risk reduction is being seen through those primary prevention. So these are the main findings that I'd like to share with you, and I want to conclude that presentation acknowledging all national and international collaborators and the financial support of research agencies and foundations that I've been receiving. And thank you so much for your time, for your attention, and I would be happy to answer your questions. I'm not hearing you for some reason.
Thank you so much for an outstanding presentation. That was fabulous and so interesting and informative. Such an important area of research. I'm sure all of us were thinking about many different clinical situations, especially as nurses, but also some personal situations, whether it's ourselves or family members or other things. So, you know, thank you for sharing that incredibly important, the studies you've been doing and the information you've gained. One of the things that struck me, you know, first of all, I want to share with our audience that if you have any comments or questions, please feel free to put them into the chat. You can also raise your hand and Jenny will unmute you and you can share your comments or questions aloud. Michelle is saying, thank you for this presentation. This research is fascinating. And I totally agree with that.
Thank you. Thank you so much for your feedback.
Yeah.
It's important to keep us motivated and reduce the stress of our work.
Yes. And Dr. Donna Fick, who is the director of our center, Says excellent presentation and congratulations on your dissemination and advancement of the science. We are happy to have our Iowa partners teaching and learning with us. So
Good.
one of the things that came to mind, for me is we've been doing a lot of community education for care partners that have loved ones living with dementia. And they're always very curious about trying to understand what's going on with the brain. And as you were describing how prolonged stress impacts the brain, I was very much reminded of a person with dementia and what's going on with their primitive brain, the amygdala, the hippocampus, that fight, flight, or flee response. So as you're describing what causes prolonged stress and what's going on physiologically, that also relates to what's going on for the person with dementia and how they're responding to their environment, to social interactions, how they display their stress, distress, and unmet needs. Can you comment at all about that a little bit?
Yeah, sure. So first, thank you so much for all comments and generous comments and appreciation of the presentation. I'm really passionate about that area and especially because I see so the importance of nursing and interdisciplinary team working on that for changing the projections that we have in terms of our brain health. So I've been thinking about a lot, especially about caregivers and about the stress that they face over the course of the caregiving period, which could be 5, 10, 15, and even more years. Mm-hmm. And we are talking about people that are already in the aging stage, or at least very close to that. So, and how vulnerable they are to those effects of this prolonged stressor that is taking care of someone. And the main reason that we can connect the stress consequences of taking care of someone is because taking care of someone with dementia means to deal every day, or at least very regularly, with new situations, changes in behaviors, changes in their physical ability, changing in the way they can communicate with others around them. Low sense of control or no sense of control, because what I can do, my goodness, that person, it's not what I'm supposed to live with. I don't know how to deal with that. I don't know how to handle those changes. And I cannot change that because I've learned that this is a chronic condition that can long last for years and that you get worse. And the other point is I can be evaluated by others by the way that I treat my family member. So if my family member doesn't see in a good health, this is my fault. So we have all the components of stress in caregivers. And the main problem is that they are in the older aging stages, which means they are much more vulnerable. And it's not surprising why we see so many of them getting sick or developing chronic conditions such as hypertension, diabetes, depression. They isolate themselves, so they increase their risk factors and also reduce their protective factors. What is intriguing to me is that we put a lot of focus on the stress of caregivers, but we don't see them as a potential person to develop cognitive decline soon because they are exposed to all those psychosocial stressors and without adequate support. And we have a lot of questions around caregivers, but we also have a lot of barriers, especially related with interventions. So what is the best time to implement that intervention? What is the best strategy? There are several studies showing like group interventions, trying to provide more mindfulness, trying to increase physical activity. All those interventions are really very important and essential to increase resilience. But we also need to explore what are the individualized interventions that we need to consider. But to do that, we really need to understand how to measure that cumulative damage, how to measure and monitor the effects of stress on their lives, and how to motivate them, and not only motivate, but use feasible interventions to keep them engaged, and also show them how those interventions has been effective, because we can monitor in a personalized way the risk, the intervention, the effect of intervention, and then how that can reduce their risk for cognitive decline, and also improve their overall health while they are caregivers. So there are a lot of things to talk about that. So I'm sorry if I'm
No,
wrong,
that's
but
fabulous. I mean, as you're describing, all of the physical and psychosocial stressors on a care partner, it's reminding me of the beginning of your lecture, talking about those 4 areas of novelty, unpredictability, the threat to the ego, not feeling competent, and that loss of sense of control. So thank you for sharing all those insights. And certainly there's all kinds of opportunity for additional research related to that.
exactly, yeah.
Dr. Diane Barish wrote a comment and had a question here. Let me see if I can find it. Because with advances in geroscience research, do you see the future of prevention interventions being focused on younger and younger ages?
Yeah, this is a very interesting area, and I would say a hot topic area, especially in the field of stress. And I think this is possible, especially because of the development of artificial intelligence. You're going to see me saying that several times, but this is what we are seeing right now. And I've been reading about, maybe Dr. Diane, you also read about it. We have been learning about exposome framework. So exposome framework means that you are going to put in the model different types of negative exposure, which could be pollution, it could be your neighborhood rate of violence, it could be accessibility to healthcare system, which could be accessibility to basic things that it's basic for your survival in the beginning of life. So this exposome model would be connected with different types of responses from our body, not only in a macro level, peripheral level, as I showed here, but also in a cellular level, showing changes in our DNA, in our proteins, in our inflammatory reaction, and then explaining potential risk for developing health outcomes. So although these are just like the way we envision the science, I truly believe that in the next in the future, and with all those technology being advancing, we could go in a more in-depth way to explore the effect of all those things related and detect what are the personal risk factors and how we can use those findings to advocate for changes in our environment, not only environment as atmosphere, but everything that it's related with our consumption of products, our accessibility to things that protect our body, and increase our resilience. So I think everything that relates to our environment.
Yeah. Well, you certainly shared a lot of really great frameworks and models during your presentation that was really helpful to understand, many of the concepts, as well as, how you conducted your research. In a similar and kind of probably a related question that Donna is asking is, do you see any future research relating this to different personalities and psychological grit, or how some deal with trauma and stress, yet still persevere and maybe don't go on to experience cognitive decline in Alzheimer's?
Yeah, absolutely. So when I say this complex, when I mention these complex models, we need to consider the individual characteristics. So personality, it's one of them. So when I show the 4 determinants of stress, the novelty, unpredictability, sense of control, and threat to the ego, it means that they are capable of triggering the stress response, but not all of them, not all of us are sensitive or sensible to all of them. Some people would be okay with novel situations, but they won't be okay with social evaluation. Some people would be okay with social evaluation, but they just can't tolerate not having control over the situation. So these are the examples how personality can shape the way we respond to stressful situations over the course of our life, and also how we need to consider that, not to change personality, but to design interventions that can fit to that personality main characteristics, and what are the behavior changes that we can work with the individual in order to turn this personality a resilient factor and not a risk factor. So the way they face things could be used to power them, not to put them in higher risk. So absolutely.
Yeah, and we were all pretty fascinated, I'm sure, by the studies on nurses, and Michelle Black asks, and this is probably our last question, I'm afraid, do you think this research will move towards developing ways to reduce, oops, sorry, that moved up on me, towards developing ways to reduce workplace stress and its impact on nurses? Any thoughts on that?
So.
I hope so too.
I hope so, especially because we are showing that it's a combination of environment and individual characteristics explain that high risk of negative effect. So we cannot ignore the impact of our environment have on the way that we respond to some stressors in our environment. So we have a lot of evidence showing that, and we just need to advocate, not just, I would say, we need to be more persistent in using evidence to advocate for our well-being when we are in our workplace.
Yeah. And Diane comments that it's not only applicable to nurses, but to all of us, and absolutely, right? One of our PhD students, Ahmed, says that this was, and I think this is a great way to close before we put the link to the evaluation tool in the chat. It's an excellent presentation, and he enjoyed it very much. Is interested to learn about the risk factors that can predict cognitive decline apart from age and other things. And again, thank you for sharing your expertise related to persistent stress leading to more cortisol and the impact on cognitive decline. So I agree. I think that's a great concluding statement that I think we all learned a tremendous amount today, gave us some things to think about in terms of our own personal well-being and how we manage and deal with stress on a regular basis. Also, perhaps how we can better support other people when they're going through difficult situations, right? So thank you so much for joining us today. Jenny will be putting the link to the evaluation tool in the chat. We do encourage everyone, it's in there already. We do encourage everyone that attended the seminar to complete the evaluation tool to give us feedback on the seminar as well as ideas for future planning. I hope that everyone joins us in a couple of weeks for Dr. Anju Padel's presentation. So thank you again, Juliana, for this fabulous seminar. Thanks to Jenny and Amy for your help and support. And I hope everyone has a great rest of their day.
Thank you. Thank you so much. It was a pleasure to be here.